All right, we're going to move into gait deviations. Foot drop, also known as a steppage gait. What you will observe are the toes fail to clear during swing. Exaggerated hip and knee flexion, also known as high stepping. It's often worse with fatigue or increased walking speed. And it may be presented unilaterally or bilaterally. Biomechanically, it's failure of the ankle dorsiflexors during swing. Tibialis anterior and deep peroneal muscles cannot concentrically dorsiflex. The foot remains plantar flexed, which then leads to toe drag risk. The patient compensates proximally to maintain clearance. Why it matters clinically? These patients are a high fall risk. It's increased metabolic cost. It can lead to secondary hip and lumbar overuse, and often indicates neurologic pathology, not just weakness. Assessment: you will want to observe swing phase closely, not just stance. Compare early versus late gait, the fatigue effect. You also want to test dorsiflexion in open chain and walking. You'll also want to screen sensation and reflexes to see if there's peroneal involvement. Corrective interventions: dorsiflexor strengthening with the use of bands, toe raises, or heel walking. Use of NMES during swing. And then task-specific retraining, such as marching drills or ambulation on a treadmill with using dorsiflexion cueing. AFO if safety is compromised. Foot drop is a swing phase failure, not a stance phase problem. Foot slap: what you will observe: an audible slap after heel strike. Heel contacts ground normally. The forefoot drops rapidly. It's often subtle and missed without listening. Biomechanically, it's poor eccentric control of plantar flexion. Tibialis anterior fires, but cannot decelerate foot lowering. External plantar flexion moment overwhelms dorsiflexors. Clinically, why it matters: it's an early sign of dorsiflexor weakness It's a precursor to true drop foot, and it increases impact forces at initial contact. Some assessment pearls. Watch loading response and not swing. Compare barefoot versus when the patient wears a shoe with their gait pattern. You want to test eccentric dorsiflexion control. And then you want to look for rapid pronation immediately after contact. The corrective interventions is eccentric dorsiflexion training, such as slow lowering drills, heel walking for endurance, and balance training to improve neuromotor output and control. A common gait cue that you'll hear is using quiet feet. Foot slap is controlled poorly. Foot drop is uncontrolled completely. Excessive pronation. What you'll observe is the medial arch collapse during stance. You'll also see calcaneal eversion. You'll see medial tibial rotation. And it's often asymmetrical in stance. The biomechanics, it's the failure of the foot to resupinate in mid/late stance. It's generally with weakness in the tibialis posterior and the intrinsic foot muscles. We have perineal dominance, and midfoot remains mobile instead of becoming rigid. Why it matters clinically: it increases tibial internal rotation, thus leading to knee valgus. It alters patellofemoral mechanics. It increases stress on the plantar fascia and the medial ankle. It's also a common contributor to overuse injuries. During assessment, you want to do observed barefoot gait, assess single leg stance, which usually reveals the collapse pretty quickly. You want to be able to palpate tibialis posterior during heel rise. And then you also want to check midfoot mobility versus rear foot alignment. Corrective interventions. You want to work on intrinsic activation, such as short foot exercises and toe yoga. You want to do tibialis posterior strengthening, such as resisted inversion with plantar flexion. You want to do balance training, emphasizing arch control. And you can do orthotics education or taping for structure. Pronation is normal. Failure to resupinate is the issue. Now excessive supination. What you'll see is a high medial arch, calcaneal inversion, lateral weight bearing, and reduced foot motion throughout stance. The biomechanical mechanism: foot remains rigid throughout stance, thus leading to poor shock absorption, having weak perineals or overactivation of tibialis posterior, and structural cavus often present. Clinical importance: it increases impact force. You lead to a higher risk of stress fractures. You have lateral ankle instability and poor terrain adaptability. During your assessment, you should check lateral shoe wear pattern, assess peroneal strength and reaction time, evaluate rear foot mobility, and for athletes, single leg hop, revealing poor shock absorption. Corrective interventions: perineal strengthening, such as resisted eversion with a band, or lateral band walks. Intrinsic foot activation, so toe spreading and working on unstable surfaces. Mobility work of the plantar fascia and your calf. A rigid foot protects stability but sacrifices shock absorption. Toe walking. What you'll see is an absent or delayed heel strike, persistent forefoot contact, and it's usually bilateral. It also may increase with speed. Mechanically, it's limited ankle dorsiflexion range of motion. You have tightness in the gastroc/soleus. It also could be spastic plantar flexors, such as CP or other neurologic cases. And it can be, for some patients, a habitual motor pattern in pediatrics. Clinical importance: it eliminates the heel rocker. It increases knee hyperextension risk. It raises energy cost. And again, it limits shock absorption. When assessing these patients, you want to test dorsiflexion with the knee flexed and knee extended. You want to observe barefoot gait mechanics. You also want to check Achilles length and tone. And also you want to differentiate between someone's habit versus an actual structural limitation. Corrective exercises: calf stretching and eccentric heel drops, dorsiflexion strengthening, again with resisted bands, or also performing heel walking, and then doing gait retraining, emphasizing on heel strike, or using a treadmill for heel contact emphasis. And then some patients may need orthotics or serial casting if indicated. Toe walking is usually an ankle problem, but it also shows up at the knee. Heel walking, or also known as absent push-off, you will see minimal heel rise, flat foot during terminal stance, a reduced stride length, and slower gait speeds. Biomechanically, there's weakness in the gastrocsoleus complex. You may have pain or inhibition, usually due to Achilles pathology. You also may have inadequate ankle plantar flexion power. Why it matters clinically: it decreases forward propulsion, it increases proximal workload, and it reduces walking efficiency. When assessing patients that have this, you want to look at single leg heel raises for endurance. You want to observe terminal stance carefully. You want to compare step length bilaterally. And then you always want to ask these patients about forefoot or Achilles pain. Corrective interventions: progressive calf strengthening, such as calf raises, seated soleus raises, plyometrics when it's appropriate, such as pogo hops and bounding as tolerated, and functional drills, really working on push-off. No push-off means the hip has to work overtime. Pigeon-toed gait, you'll see the toes are pointed inward during stance and swing. Often bilateral, and it can worsen with fatigue. Mechanically, there is excessive femoral anteversion. There is tibial internal torsion. And there's excessive pronation causing tibial internal rotation. Clinically, it alters the knee alignment. It increases fall risk. It's often understood as a foot problem. When you assess these patients, you want to observe the patella direction versus the foot. You want to assess hip rotation, range of motion. And then you want to look at the limb as a whole not just focusing on the foot. Corrective interventions, doing glute strengthening, such as clamshells or hip abduction with bias on external rotation. Foot intrinsic control, such as working on short foot or resisted inversion/arch control. And then neuromuscular retraining, providing tactile and verbal cueing, and then also using foot alignment markers to help these patients. In-toeing is usually driven from above the ankle. Out-toeing, or also known as duck foot gait, you'll see the toes are pointed outward. It's often asymmetrical, and it may increase with speed for some patients. Biomechanically, we have femoral retroversion, tibial external torsion, and for some, it can be habitual compensation for stability. Clinically, it alters the push-off mechanics. It increases medial knee loading, and it can mask hip weakness. When assessing these patients, you want to observe knee-foot alignment. You want to assess hip internal rotation. And then you want to check their step width and trunk posture. Corrective interventions, biasing hip internal rotation strengthening with resisted internal rotation, whether it be side lying or seated with a band. Working on glute med stability, such as side lying hip abduction or step downs. And gait retraining, using visual cues to keep the toes in neutral. You can't cue the foot if the rotation comes from the femur. So again, clinically, always observe being barefoot versus having a shoe on. Also, overground versus the treadmill. You want to link the deviations to strength, range of motion, neuromuscular control, and pain. Again, treat functionally, not just locally. Again, EMG is just confirming that we have delayed or reduced signals correlating with overuse injuries, compensations, and reduced efficiency. EMG confirms what your eyes suspect. The ankle-foot complex alternates between mobile adapter and a rigid lever. Efficient gait depends on timing and not just brute strength. And deviations reflect impairments that must be addressed globally and not in isolation. Most ankle-foot gait deviations are not an isolated foot problem. They are integrated motor patterns involving the entire kinetic chain. Your job as a clinician is to identify where the deviation starts, not just where it shows up. Again, please refer back to Perry if you have any other questions to that, or please email me. Thank you.